So hi everyone. If you guys don't know me, I am Kat Trauman and I'm the Assistant Director of Research at PXE International. I wanted to thank everyone for spending at least some part of their Monday with us for the first talk, part of the PXE International Extended Virtual Conference. For these meetings, our speakers will give a presentation on a topic of their choice, and then the floor will be opened up for questions while I and other members of the PXE International staff moderate. So I see I have Mary and Georgia here with me today. So as a reminder, they will also be recorded. Like I should have got a notification to approve that, and they will be uploaded to our YouTube channel so you can view them later on. So for today's presentation, I have the pleasure of introducing Dr. Kristina Pfau. She is a clinician-scientist from the University of Basel in Switzerland. She focuses her research on inherited retinal diseases and also degenerative diseases. So today she will show us some of her baseline data for her study on light-dark adaptation in individuals with PXE. So I'll pass it over to you, Dr. Pfau.
Dear Kat, dear everyone, thank you so much for joining. It's a pleasure to see so many of you tonight, or like for you in the afternoon. My name is Kristina. I'm one of the consultants at the University Hospital in Basel. And before that, I was working in Germany, where we have one of the largest PXE cohorts in Europe. So I've done all my research so far on PXE. And now we have set up a large prospective study. That means that we see patients over 2 years in Basel. And I will now present preliminary baseline data from that study. We have not analyzed all data yet, but some preliminary data here. So let me start here. You should see on my screen. If not, please tell me.
Yep, we can see it.
Perfect. And you can see my pointer?
Yes.
Yeah, perfect. So I just a second ago I've put in just a basic slide, sorry, because I always start with telling something about the retina, but sometimes it's good to remind ourselves where the retina in the eye is, because the eye is actually quite large and the retina is a very thin layer at the back of the eye that's here. And all the other structures like the cornea, which is a clear window in front of the eye, the lens, they are, as far as we know, unaffected by PXE. There is like a jelly that's called the vitreous, and then at the back of the eye, that's your retina, and that is what where the alterations in PXE appear. And when we ophthalmologists look through your cornea, your pupil, into the back of the eye, the image that we see is this. So this is the optic nerve that is like the cable that brings the information to the brain. And here are the vessels that supply the retina with oxygen. At least the inner retina, they supply with oxygen and nutrients. And then you have all the cells, so the whole tissue is this brown-yellow area. And in this image, you can see that in PXE, this is an eye from a PXE patient, there is this whitish area here in the center, and then there's a red area outside. And that's a very typical image of a PXE patient, because the red area outside here, that's the normal retina, how it should look like. And in the center here, there is an area which is affected by calcification, which happens in PXE, as you know. And what happens in the eye is that a thin layer in the retina is calcified. And this thin layer calcifies because it has abundant elastic fibers. And the calcification of elastic fibers is one of the main problems in PXE. So that's the image you see here. You see the calcification of this area in the center. And then you also see that there is like a transition zone of not really whitish, not really reddish area. That's called the peau d'orange. So that's the transition zone between the already calcified area and the uncalcified area. And this zone moves peripherally throughout life. So in this patient, there is a central area that's already affected and a peripheral area that's not yet affected, but this transition zone will move peripherally with increasing disease severity or increasing age. Then we have, so peau d'orange is French and it means orange skin. I think that's because back in the day when the ophthalmologist looked into the eye, it looked like an orange peel, but we can now see it much better. It's more like a mottled marmot kind of area. Then there are areas or characteristics in PXE that are called angioid streaks. Angioid is again comes from like angiology, like the vessels, angio. And that's because when we look into the eye, they look brownish, reddish, quite similar to the vessels that we have. So they quite resemble vessels. That's why they're called angioid streaks. But actually, they are breaks in the calcified Bruss membrane, so this calcified area underneath the retina. And that's why they only appear in this whitish area. We don't have any angioid streaks outside of this whitish area. They always are inside here. And you have to think of that calcified area as a little porcelain, very brittle area or layer. And that's why we also tell the patients that they shouldn't get a punch on the eye, so no contact sports, or at least wear protective glasses, because they can really aggravate. These breaks in Bruss membrane can really aggravate when you have a punch in the eye. And then we also know from previous studies that patients with PXE have a delayed dark adaptation. So what does that mean? That means that many of you experience problems when you drive into a tunnel, or the light in your house is suddenly turned off, or you go to a cinema. So these quick changes from dark to light and light to dark, that's a problem. And that might be because of this calcified layer in the eye. The problem is that some of the nutrients cannot reach your cells that mediate the vision quickly enough. So our rationale for our study was that there are several therapeutic approaches for PXE emerging, but the problem is that we need an outcome measure. An outcome measure is the parameter that we measure and that we want to stop or slow over 2 years when patients get the medication. So normally there are two groups. There is a group that gets a real medication, and then there is a group that gets a placebo. And then we observe a parameter or multiple parameters over 2 years, and we want that the medication group has less severity in that parameter than the control group. And the problem in PXE is that it's something that you all have since you were born. It's a genetic defect, and it's really, really slow. And then you could say, okay, then we do clinical trials over 10 years or 20 years, but clinical trials are quite expensive. So the pharmaceutical industry is quite or needs a clinical outcome measure that we can measure within a few years, because otherwise it's not payable for them to make a study. We know that there are these dermatologic alterations. They appear early. Many of you tell us that that's the first thing you notice, that they are altered, or that was the first symptom that you had, but they progress very slowly. And then there are the vessels that can be calcified, and that appears to be later in life, but also the quantification is quite difficult. So quantification means to give the alterations a value, so a number. That can be sometimes a bit difficult. And so now the advertisement break for the ocular alterations, or for like the ocular measurements, they are early visible, they are slowly progressive, and they are imageable, so we can do imaging non-invasively, which is good because we don't have to inject anything, we don't have to do radiation and so on. So that's why we think that ocular alterations in PXE would be good for future clinical trials. But unfortunately, no longitudinal data to date is available, so we don't have a clue, or only a few information on how long it takes to monitor or to measure progression. So previous structural changes that have been described in PXE is, for example, in several imaging modalities, that there is a transition zone between calcified and uncalcified retina. This is very subtle here and here visible. Then there is also, we have some information here that this is progressing with age. So on the x-axis, you see the age And then there is a temporal border of this transition zone. So temporal means here outside in your eyes. So it's moving out like to the periphery. And that's when you do cross-sectional data. So you look at a group of patients and you plot the age on the x-axis. You can see that the central border moves towards the periphery in older patients. And then we also have OCT, which is the cross-sectional imaging of the retina. And also here we have some information that we can measure and visualize these alterations at the level of Bruch's membrane. And that's these black areas here, which you can see. That's not a clear line. That's more like more black areas and then less black areas. So that's probably the calcification that we can measure. And then again, the Dutch group, which is very, very active also in ophthalmological research in PXE, they also showed that we could measure a difference. So again, quantify these alterations that you can see up here. So OCT can also be valuable. Then there are some structural changes that arise indirectly from PXE. So for example, this vessel layer that is underneath or outside of the retina, it's called choroid or choriocapillaris. That is also thinned in PXE. And we were also able to measure that over time, or we could show that over time this layer gets thinner. So the vessel layer that actually supplies the retina with nutrients, that gets thinner over time. And when you look at that more closely in a more novel or new device, which is called OCT angiography, you can see that even in patients that have no or only few alterations, we were able to measure small flow deficits, which means there was no flow in this capillaris layer. So functional changes that have been described before were, of course, best corrected visual acuity. So the visual test that's done probably at all your visits at an eye doctor. But the problem is, and that was again the Dutch group that has shown that it's very, very good. So 20/20 is normal vision. It's like, say, normally 100%, which is not quite accurate, but some patients say that. And it stays like that a long, long time, and then suddenly it drops, and then it doesn't recover. So it doesn't have to be in every patient, this pathway. You see there's a big variety in it, but all these factors that it stays the same for the long time, then there is a decline with high variety, and then it's on a floor effect or floor. That's all characteristics that are not really good for a study, because if we measure this parameter in young patients, you can treat patients or treat not patients. They don't have a difference because no decline is visible. And then in this middle group, there's much variability, and in this older group, they probably already have bad visual acuity, so that would not be a good parameter to test in clinical trials, but it has been used before. And then there are tests that actually test the rods, which are your photoreceptors, the cells that mediate your dark vision. And we think that is one of the better possibilities to measure the dysfunction in PXE. Why is that? There is a test which is called dark adaptation. Probably none of you have done it, apart from the people that I saw that have been part of the study here. So the idea is that we bleach the patients. That means that either they look for 10 minutes into bright light, or there's a flash that bleaches the photoreceptors. So the idea is that all the nutrients in the eye are depleted. So the eye is kind of in a state adapted to very bright light. And then from that on, the time starts to run, and the patient gets a stimulus somewhere, so a little light, which is always getting darker. And the patient has to click when he or she sees the light. And then when he or she clicks, we know the light is seen, and then we can put it a bit darker. It's, of course, everything is automated, and it gets a bit darker. So it's a bit like perimetry, which you might visual field testing, which you might have had, but it's normally at one point and you test over time. So it's a dynamic testing. Yeah? And what you get from it is this curve. So the x-axis, again, the time, and the y-axis is how bright the stimulus was. At the beginning, it's very, very bright, and then over time, patients and controls adapt to a dimmer light. And in black, you see the controls that we've tested, and in gray, you see the controls. Sorry if it's very, very, very thin lines. I should have made it bigger. Sorry about that. But what you can see is that the controls are quite monotonously decreasing over time, and the PXE patients, they have some troubles to adapt to a certain light level. And that is something that probably we can measure quite early in the disease. Yeah. And then, of course, there's also just the steady state rod function, which means that you don't do the dynamic testing, but the patient just has to adapt 30 minutes. So the patient just sits 30 minutes in the dark, and then we test the sensitivity at the retina, which is then, the advantage is that we can test multiple points here, which you can see here. All the colorful dots here is a test spot, and then we can see the specific sensitivity at this locus for the patient. And then, so the unmet need that we have is that for all these functional or dysfunctions that we know exist, the progression estimates are based only on cross-sectional data. So we just see that older patients have more problems than younger patients, and we can draw a line, but we don't know for the individual person if that's their pathway, or if there are different, maybe or inter-individual differences. So our study had the aim to measure first calcification of Bross membrane. So once in this image that I showed you before, so how quickly is the border progressing towards the periphery, and then also in the cross-sectional OCT image, then the thickness of the choroids, so this vessel layer, how quickly is that thinning, again on the cross-sectional image and in this novel technique. And then as a third parameter, this dark adaptation that I've just explained. We want to see, can we measure a difference in dark adaptation over 2 years? So is it declining over 2 years? That would be interesting to see. And therefore we have set up or created a novel device which can test not only at one location, but at 3 locations. And the idea is also not to find out if dark adaptation is a good parameter to test visual function in PXE, but also to test it at different locations. So do we have to test within the area of calcification? Do we have to test at the border, or do we have to test outside in the normal retina? Because we still have to find out where the best location is to measure progression over 2 years. And that's what the novel device can do in one test. So our preliminary data was that we had 30 eyes from 15 patients. There are still 10 patients that we have to analyze, but that's the preliminary data. The median age was 56.2 years. The age of onset that they reported was about 20 years, and the age of diagnosis was 25 years. There was a big inter-individual difference, but interestingly, they had a median of 5 years between symptoms and diagnosis, and that tells us also that we still have a long way to go for clinicians, physicians to recognize PXE, because actually, as an ophthalmologist, when you see the eyes, it should be clear, and with the skin together, it should be totally clear. And I don't know how it is about the vascular part, but I think we still have to give a lot of talks maybe to colleagues, or increase the awareness that there is this disease. The BCVA, so the best corrected visual acuity, was very good. So this is logMAR, which means that 0 is good, is about 100% or 20/20. And we also measured the contrast sensitivity. So for the dark adaptation, I told you that we have measured at several locations. But the question is, when we have this curve, which value do we take from it? Do we take the time until the certain adaptation, what kind of value do we take from it? And the idea is that there is a threshold, which is an area where you can more or less navigate in mid-dim light, and we measure the time it takes until to adapt to this point. So it's just a time until you can see a certain light level again, so the time of the recovery. And when you look at the different, this is an exemplary patient, when you look at the different eccentricities, so this is 8 degrees from the very, very central retina, so from the fovea, and this is 46 degrees, so very, very peripheral. And I told you that in the periphery, there's more normal retina, and in the center, there's more altered retina. So when you look at that, you can see that in the periphery, there's nearly a normal dark adaptation. Then the more central you get, the slower this curve recovers. And at 15 degrees, it's already 20 minutes. And here at 8 degrees, it's already 35 minutes it takes to adapt to the same value. So within an eye of a PXE patient, there are different severities within one eye of this test. And when you now take the eccentricity on the x-axis and then this rod intercept time, which is this value, this time value in minutes, which it takes to adapt, then you can see that at 8 degrees here, at 8 degrees here in the center, it's very, very high. At 15 degrees, it's again very high. And the more peripheral you get, the slower, the quicker the dark adaptation gets. So here there are normal values about 20 and 20, and here in the center, the patients need more time to adapt to a dim light level. And this was statistically significant for all points we tested. And that tells us that this time varies significantly in dependence of the eccentricity from the central retina. And now the question is, which of these is the best spot to measure? We don't know yet. We still have to analyze all data. But if you look at the age on the x-axis, so this is a patient 40 age, this is a patient of 60 years of age, and you can see there is a steep curve here, which means that probably at 15 degrees you can discriminate best that younger patients have a better rod intercept time and older patients have a worse dark adaptation, so rod intercept time. And I won't go into detail here. That's the retest reliability. That's always important, because if we test you twice in a row, then it should be the same value. Otherwise, if it's all over the place, then it's a problem, because then for a study, it's really hard to measure. And that's an important factor, but the retest reliability was quite good for the test. And here I'm already in the summary, which is that from cross-sectional data that we have, that PXE is characterized by this centrifugal progression, so the moving to the periphery of the mineralization of Bruch's membrane, and also it goes into a degeneration of the underlying choroid capillaries, and then also the photoreceptors that are overlying Bruch's membrane are then degenerating, and that's what makes you actually the visual problems. And then in the function, I talked about this dark adaptation, and that's probably a promising candidate for future clinical trials. And in the next years, we aim to identify which of these parameters, structural or functional, is the best to test the progression in PXE. And then hopefully we are ready to go into clinical trials and test medication and find positive answers to stop or at least halt the disease, slow the disease a bit. I would be very happy if one of our results would be of help for clinical trials in the future. Thank you very much. And of course, many of you I don't know yet, but thank you to all the participants, and thank you for listening. And I'm up for questions for a couple of minutes. I don't have to run, but yeah, please feel free to ask any questions.
Thank you so much, Dr. Pfau. It was really enlightening. If anyone has any questions, just feel free. You can either raise your hand if you know how to do that reaction, or just feel free to blurt it out. We can help keep everyone in track.
Are you still wanting to recruit people?
So yeah, thank you for that question. So we are currently fully recruited. So we were aiming for about 25, 26 patients. That doesn't seem a lot, but it's a lot of work, and it should be enough power to show what we want to show if we don't lose many of them. So thank you very much. You can always, if there are questions for your disease, you can always send us an email. Some people send us images or so. If they want a second opinion, we can always do that, and you can always come as a patient. But at the moment, we are fully recruited.
I asked the question because I'm here with one of my daughters, but I've got two daughters. They're 20 and 23. So just whether somebody from that younger cohort would be of use or interest to you.
Yeah, I think we don't know. So we are planning some more studies in the future. So we might come back in the future with new studies or other studies, and then of course young patients are always very, very important because, for example, in an eye where there's always an advanced disease stage, maybe again already many injections have been done. There's a mix of characteristics, and then sometimes it's a bit hard to differentiate if the dysfunction is coming from that characteristic or that. So young patients would be, of course, always ideal. Yeah.
Okay.
We did have a question in the chat to share the email best to use to answer questions about PXE.
Oh yeah.
And if you have general questions about PXE, you can always email us at PXE International, and we can always triage and direct you into the right person.
Exactly, because sometimes also the treatment regimens for example, injections should be more or less the same over the world. But of course, sometimes patients need a physician that already has seen PXE before, or some special advice that is locally. And therefore, of course, PXE International is super helpful. And the best would be if you always copy them in CC when you reach out. So if there are no questions, either the talk was too complicated or everything is clear.
We have a question in the chat. What age do you start to see calcification in the eye generally?
So very, very early. So these small angioid streaks and some peau d'orange is early visible already in patients with 14 years of age. I haven't seen much younger patients. And normally, if the diagnosis is set, you don't do any more invasive testing. But there's also the possibility to inject a dye into the vein, which is not super invasive, but for a child, you don't want to do it. And probably we would see it even earlier in these, in even younger patients. But then, of course, it's a problem because it's ethically not really doable. But I think we can see it very, very early. Yeah.
Olivia, I see you have your hand raised.
Yeah, I do. Thank you so much for this talk. It was very informative. I just had a couple of questions because I kind of see, I've seen some folks be a little too cautious online, so I wanted to check. But is there anything that accelerates to accelerate the symptoms or the calcification rather of the eye and the angioid streaks? I've seen some people even say not to rub your eyes. And I know the general guidance about weight-bearing activities, but I just wanted to see if there's any additional guidance.
No, so there has been no trial on this, but we know that for example, a punch on the eye is bad, so no boxing, no judo, and if you do sparring or something, then of course wear a helmet. And often it's not a real punch, but for example, we had a patient that wanted to close the zipper, and then then the zipper had an elastic band, and then it flipped, and then he pushed himself into the eye suddenly, and then he had a bleeding. So these are the things you cannot avoid. I mean, you cannot run around with protective glasses 24 hours, but everything you can avoid, you should avoid. And apart from that, there is no evidence of anything else. So yeah, I mean, it's a good question. Of course, you always want to be, to protect or be cautious. But there is nothing really to do. I mean, you can always test yourself, right eye, monocular right eye and left eye, see if there are any new metamorphopsia, which means that the lines are not straight anymore. And then, of course, see a doctor or someone who can do an OCT. But apart from that, I think it's more being cautious. Yeah.
Okay, thank you so much.